Hello, everyone, and welcome to a special edition of our Scientist Spotlight series. I'm Rachel Pignotti, Marketing Strategist for the U.S. MEF2C Foundation. Today, we welcome Dr. Chung, Dr. Wendy Chung of Boston Children's Hospital, here to discuss findings from the MEF2C in-person research assessments done in October of 2024. Dr. Chung will also provide some detail on what to expect from the upcoming January 2026 assessments. Dr. Astrid Rasmussen and Claire Jones will also join us for a Q&A session after the presentation. They plan to answer any questions that you may have regarding the Simon Searchlight MEF2C dataset. Any logistics questions related to January 2026 assessments will be addressed at a later webinar with Jessica Waxler of the Chung Lab. In addition, the US MEF2C Foundation will provide continuous updates through email and social media. Any specific questions that you have at this time concerning any logistics for January can be directed to the foundation at info@usmef2cfoundation.org. Dr. Chung, we're excited to see you today. I'll hand things over to you.
Thanks for having me today. Excuse me. I'm going to share my screen. Can you see this? Okay, very good. So I'm going to present, as you said, the data from the last in-person assessment that we did, and I'm also going to share some of the data that we had that you've seen before from Simon Searchlight to realize that we try and put everything together to think about the whole person as we do this. So as we do this, just to explain, when I say natural history studies, what we mean is that we're describing what's happening to the person over time without any intervention. So what I mean by intervention is without any clinical trial, any medication, any genetic therapy. And as we do this, we try and understand the condition better to design both understanding better how to support people in the near term, but also how to plan in the future for when we do have clinical trials or interventions, understanding what the ability level of that person is and whether or not it's stable or changing over time without that intervention so that we can be prepared for being able to test something in the future with an intervention. We try and balance this in terms of things by doing not too frequently, not too sparse in terms of how when we do it, so that we minimize the burden on individuals, but that we can see change over time because our children clearly are growing and changing as they get older. As we do this, we are trying to balance returning as much information as we can to families and also realizing that this is a research study. And so as I'm doing this, I'm going to be talking about the aggregate results or the results of everyone in the family. I'm not calling out any individual person within this, but if you participated in the studies, you may be able to get a sense of where your child is based on their age. And again, as I said, how things are changing over time. I do think that as we've done this in a good way, because we've had a concentrated effort with a relatively small number of people who've been getting to know your children and getting to know the condition MEF2C as they've intensively studied many, many people with the same condition. We hope that that expertise is going to be helpful to the community by understanding how MEF2C may be different than other conditions, and again, trying to get a better sense of change over time and where we can see some differences. And what I mean by this is some of the standardized measures that we use may not be as sensitive to change over time, either because they're geared for individuals who may be higher functioning or lower functioning. And so we need to be able to right size this for the right person in MEF2C so that we can see changes over time. So with this, as we've done this, we've tried to be very, very rigorous as we've done this. So it's first defining who is eligible to be in the study. So with doing this, we've taken all individuals with MEF2C genetic variants, and just to explain some of the technical terminology, these are individuals where we truly think these MEF2C genetic variants are really associated with the condition. So the technical jargon we use is that they're pathogenic or likely pathogenic. This gives us great certainty that these really are associated with the condition. And apologies for those of you who may not have qualified yet based on your genetic results. As we have more evidence in the future that these genetic variants are disease associated, certainly will include more people with more variants over time. We've tried to be as inclusive as possible, realizing that for rare diseases, there are not many people, and so we've tried to find some way for everyone around the world to participate. And that's why I'm going to be describing both what we've done in Simon Searchlight that allows us to have individuals participate online, that opens it up to people around the world, as well as what we've done by in-person assessments. And those obviously were we had done in Boston. That allows us to directly observe those individuals. And I consider those data, excuse me, to be complementary. What I mean by that is that for the online data, individual parents or guardians have been the ones providing their observations. I actually think those are incredibly important because parents and guardians live with this 24/7. They're able to observe things that we may not observe when we bring someone in just for a 1 or 2 day assessment. And so I consider those to be incredibly important. However, federal agencies like the FDA, the EMA, other regulatory agencies that are considering data for approving new therapies, they may value also data that are seen by in-person assessments, where we can be able to verify and independently confirm what parents are seeing at home. And so having that additional data source we consider to be complementary and responsive to those agencies who will later be looking for data to include for registration packets. And so in doing this, we've tried to include both types of data. In addition, there are some research data that includes electroencephalograms or EEG data that may be finer grained in what we call biomarkers, where we may be able to see outputs from the way the body is responding or what the body is doing that you couldn't see simply by observing behavior. So those particular, whether they're blood-based biomarkers, whether they're electroencephalograms, may be early indicators of a medication getting to the brain and having an impact on the brain. And so we're using those early biomarkers or outcome measures to be able to better understand what any future medication or treatment might have on the brain and behavior. So hopefully this explains a little bit of the method that we're using and the why in terms of why we're doing it. So let me first briefly summarize Simon's Searchlight. These are, again, the online data that are collected, again, with many different languages to allow for people around the world to be able to participate. And in doing this, we, again, try to increase the sample size and the numbers. That also allows us to increase people over the life course so that we can include individuals who are both younger and older as we're doing this. This is part of a larger ecosystem that we've created for Simon Searchlight, not just from F2C, but in fact many other conditions. And in doing this, as I'm showing on the left, the many different languages that we include to be able to be inclusive around the world. This includes measures that we have both at the baseline, so someone enters the study, as well as annually, so once a year, being able to understand how changes occur over the life course. I realize this is many different measures and that this is something that I thank the parents and the guardians who are quite dedicated to doing this over time. I realize it's an investment of time, but it's something that helps us to see those changes over time. We also include within this, importantly, what we consider the voice of the community to understand what's really important to the community, what are the most important things that they'd like to see change, and that helps us to design clinical trials for the future based on what are the priorities of our families. And so this is important. It also changes over time as the community gets older, some of the children get older, but importantly, as things in life change over time based on opportunities. And so So we continue to do this on an annual basis. Just very briefly, if you log into your dashboard for your Simon Searchlight account, you can actually see that you're registered and what there is for you to do. So just very briefly, you can see the tasks there are to complete on your dashboard. And importantly, as we do this, we summarize this information in ways that are freely available to families and their providers, their doctors. And we try and do this through both publications and what we call gene reviews to be able to, again, make this for your doctors as a very simple way to see those updates and how to incorporate that into your clinical care. And again, freely available with all of this information. We also have this de-identified, I should have said that at the beginning, so that researchers around the world can access this data through something called Safari Base so that they're able to use the information. Researchers around the world, whether they're in universities, academic medical centers, or even companies that are developing new treatments. And this, again, de-identified information we put into a common database called ClinVar so that laboratories making new diagnoses for patients in the future can make sure that they do it accurately. We also have resources that are generously provided by the Simons Foundation, including induced pluripotential stem cells, so that there's actually not just data, but also biological resources available so that people can do experiments to be able to move the fields forward. So within this, we complement this, as I said, by in-person assessments. We've done this at Boston Children's Hospital under a banner that we call the Ascend study. And in doing this, we do this as a complement to what we have with the in-person assessments. We do this and include a brief medical review of the medical history, but then also detailed neuropsychometric assessments in terms of how the body moves, with our physical therapists doing motor assessments. And as I said, with neurologists who are experts in terms of understanding electroencephalograms, not primarily to look for seizures, but to understand the EEG as a biomarker so that we can see early impact. As we're doing this, as I said, these are standardized assessments as much as possible so that we can do this with other clinical sites around the world. And I say standardized assessments because other clinical sites know how to do these same assessment measures. So they're not something that only one site can do. These can be scaled to use other sites around the world with individuals who are research reliable in those measures. We've chosen those, as I said, both for neuropsychometric assessments as well as motoric assessments to understand how people move in terms of their gait, how they move their hands in terms of fine motor skills, as well as how they're able to coordinate movement. All of this, as I said, in terms of doing this with trying to balance how much time it takes and also getting as much what we think as being reliable information to be able to say where people are at and how this is changing over time. So now let me summarize the results of that information. So to start, this is from the Simon Searchlight data. Just to give you a sense of the numbers in terms of doing this, we had 144 people start the Simon Searchlight process. We had 122 people submit their genetic test reports so that we could review their eligibility based on their genetics, and based on that, 86 individuals who actually started then entering medical history information, and then 100 total starting to do various different measures. To show you the diversity genetically of the community in Simon Searchlight, this is showing the genetic differences in this lollipop plot. Each one of these dots represents an individual person, and as you can see, there's clustering of individual genetic variants that go in different parts of the gene. Without going too deeply into some of the details, there are individual domains within the MEF2C gene where we tend to see clustering of these genetic variants, and there are certain positions where we see more than one person, not because they're genetically related to each other, but because they represent individual events. So as an example, at amino acid 15, we can see that in fact there are two different amino acid substitutions that we see, both with the cysteine as well as histine, and there are many different individuals with each of those two different amino acid substitutions. I won't go into all the details, but there may be some differences between individual positions as well as individual variant types. And over time, I hope that we'll be able to understand some of those patterns so that we can have greater specificity in terms of prediction, what those clinical features are as well as the clinical outcomes. But overall, I have to say that there are more similarities than differences across the different genetic variations. All of these are associated with neurodevelopmental challenges. And again, there are more similarities than differences, even though we have different variations as well as different amino acids that are affected across the gene. Again, this is representing the Simon Searchlight data. We have many people from around the world. I think this is representing mostly where genetic testing is done based on clinical indications. We also have research studies like SPARK that feed genetic variants into this community. So this is representing mostly clinical genetic testing, but also some research studies that we have that are feeding into this as well. And again, we're trying to increase the number of languages so that we have greater representation around the world. Now to show you some of the data and to be very clear about the limitations of the data that I'm presenting. This is based on 57 individuals in Simon Searchlight who've presented data. One of the limitations is the age spectrum that we see. So I'm showing you the ages along the x-axis and showing you each of these are age 1 through 20. But importantly, not that I don't think they're individuals over the age of 20, but we don't have them yet within the Simon Searchlight registry. And again, not that I think they're not out there, but I think they have not necessarily accessed clinical genetic testing or research studies that identify MEF2C as their diagnosis. And so one of the gaps to fill, and I'd be curious if anyone has suggestions, I have some ideas about how to fill that gap, but we want to make sure that we in fact are identifying people across that age spectrum because that helps us to identify and anticipate problems in the future and try and mitigate those issues, try and get ahead of the curve by anticipating those issues that we might see for individuals in their 20s, 30s, 40s, or 50s. As you'll see, most of the individuals in the community or a large population are young individuals, and that's in a good way because we're accessing genetic testing, we're realizing the value of that early in life, and so more and more individuals are accessing testing early, but of course we don't know the outcomes for those individuals, so we are somewhat limited in terms of what we can say over the entire life course. As we do look at individuals and understand what the challenge is, they're mostly focused on the brain and behavior. That's not a surprise. Many of you realize this already, but we're trying to get better specificity in terms of exactly what those challenges are. And importantly, I do think over the next decade, we've got tremendous opportunities to understand how to support individuals better and how to be able to improve those outcomes by helping to support early development of language or communication, if not language itself. So as we do this, we do see significant problems with language impairment, developmental delays, and/or intellectual disabilities, and a significant number of individuals, 39%, who often have autism or other associated features like attention deficit disorders. We do also see associated medical conditions. I'm happy to say those are not the predominant features, although we do see certainly significant issues in terms of seizures. I think seizures in particular are an important consideration because seizures are treatable, and if not treated or not recognized, that electrical activity can cause issues in terms of brain function in the future. So that's a significant opportunity to be able to recognize and treat those conditions. We also see some orthopedic issues or some issues in terms of what we think of as in terms of the bone or the spine. Those can be issues that can be treated with bracing in certain circumstances or also supports, sometimes even requiring surgery, but those can be supported importantly. We can see issues with growth or endocrinological issues with short stature or failure to thrive. Those are oftentimes not needing to be treated, but just to appreciate the growth curves for these individuals may be different for others. And so appreciating that and understanding what does and doesn't need treatment is important. We can also see gastrointestinal issues in up to 46 or almost 50% of individuals that include issues like gastroesophageal reflux disease as as well as constipation. And thankfully, it's not common, but we can see kidney issues, heart issues, and autoimmune issues in a minority of individuals. Again, these are not very common. Again, now drilling deeper into the neurological conditions or the brain conditions, which are the predominant feature. Low muscle tone is almost universal, and I know many of you realize that, in movement conditions, which are largely related to problems with coordination of movements, problems that may be related to how the body sort of is controlled in movement disorders. These are problems that, again, with practice can sometimes get better, but realizing that that practice is oftentimes and that development of improvement can be slow. So it does take quite a bit of physical therapy, individualized one-on-one therapy to help those problems with coordination. That can be impaired sometimes with visual issues that can be related to cortical visual impairment and the muscle tone issues. And so, again, those oftentimes require patience and a really good provider to motivate the children because it does take a lot of practice. Within this, as I alluded to, seizures can come in a variety of different flavors. They can be everything from grand mal or tonic-clonic seizures that can be very readily recognized, but also some that may be more difficult to recognize. Petit mal seizures, where they may not be those same movement disorders, but where your eyes may be staring off in one direction, or where someone may be just looking like they're staring forward, may seem to be a little bit more dazed or out of it. These different type of seizures, as I said, if you do have concerns, to be able to take this to your doctor, your pediatrician, or your neurologist if you have those. And seizures, importantly to realize, although we tend to see them on average starting at 3 years of age, they can start from a very, very wide onset, everything from 1 year to 19 years, so over a very, very wide range. On the other hand, an important issue is that seizures are very readily controlled. And so with this, being able to prevent future seizures, for this condition, we often see that medication and oftentimes just a single medication can be quite helpful. Vision issues are important because vision is one of the two major senses for information to be coming in and for children to learn and to be able to navigate their world. So vision is important, and recognizing that vision issues can often be treated. So we do see sometimes issues with crossed eyes or lazy eyes or a strabismus. Sometimes these need surgery or patching to be able to treat. So if you do see this, important to be able to take this to your doctor. And then problems that we can see that can be fixed with glasses. So whether these are problems oftentimes with seeing far away or being myopic or farsighted, again, easier to see with glasses and corrective lenses for this, and in some cases other more complicated things that we can see with depth perception, which makes it difficult in terms of especially motor skills and fine motor skills as well as safety. Much less common, and so I won't take much time, are associated, as I said, with endocrine issues or short stature, mostly realizing that growth may be different and not trying to go too far overboard in terms of growth hormone for treating this. Orthopedic issues may change over the life course, and again, we have mostly young children. I won't be surprised if we see scoliosis during teenage years when growth is more rapid and with hypotonia leading to problems with curvature of the spine. So something that we'll continue to take an eye on in the future. I highlight medications that have been used because that often gives us some indication of how severe the condition is, and importantly, that the treatment can be useful. Seizures we see for over half the children being treated, and that helps to prevent future issues. Even cannabidiol can be useful both for seizures as well as behavioral issues. And importantly, sleep can be an issue and oftentimes treated with melatonin for sleep. And sleep important as individuals are learning and consolidating a lot of what they're learning during the day. So sleep is a priority for me in terms of making sure that we help with sleep hygiene, not only with medication, but with regularity and with the environment, the sleep environment, to create a good sleep environment for children to be able to get a good night's sleep, and families also to get a good night's sleep. And as I said, gastrointestinal issues, diarrhea, constipation, reflux, that can be treated oftentimes with diet as well as medication. Um, Oftentimes people ask me about medications for seizures, and I'm not necessarily saying for your child this is what they should use. You should talk this over with your doctor. But these are some of the medications that have been used, and just reporting to you that oftentimes this is with a single medication, oftentimes medications that are routinely used in epilepsy, and so oftentimes requiring just a single medication. Let me go into the Vineland is an adaptive behavioral scale that parents can report on. I like this as a measure, not just for MEF2C, but actually for many conditions because it works across a very wide age spectrum. And parents, we find, are able to accurately report on these items. With this, we can see that there are a variety of issues that are impaired. Individuals in a good way are gaining gross motor skills, in particular, learning to be able to walk and to get around. This is important as they explore their environments and begin to learn. And so for those of you with young children, I do think this is a milestone they'll be achieving. It may be a little bit delayed, but important to be able to use that as a goal for their physical therapist. Next, in terms of fine motor skills, the next important milestone are different items in terms of personal care. And again, over time, they are able to do things in terms of being more self-sufficient and independent, and being able to do more things in terms of, for instance, feeding themselves, being able to get undressed, and being able to cooperate in terms of personal hygiene. With language, language is something that's more challenging. And I think it's important to realize that expressive language can come in many different flavors, not only verbal, but I will say that one of the things we really realized in looking at direct assessments is that receptive language is much better than expressive language. And so I think a goal for us as a community is developing methods where we can do alternative methods of expressive language because the children are clearly understanding more than I think people are realizing based on how they can speak. And in doing this, as they're able to express themselves, I do think we have opportunities for greater social engagement and social development to hopefully minimize the number of individuals with autism or autism-like features as we're able to help them engage with the world around them. As we did this, we do have a standardized assessment called the Child Behavior Checklist. Again, this is another one of these standardized assessments that parents can report on, and realizing that some of the issues over time as children are getting older, between ages 6 and 18, are related to some of those issues with difficulty with sleeping and distractibility. And so that is limiting to a certain extent the amount of time we can spend in therapies and how they're learning. And so having briefer pulses where we can still have them focused, I think is one of the strategies we can use in learning. So switching now to the complementary information that we learned from the in-person assessments that we did in Boston. Again, these were done last October, and it's based on 33 individuals. So again, somewhat limited number of individuals, but on the other hand, I think 33 is a good number in terms of doing those assessments. We did have individuals across, they're still young, so we did skew towards younger individuals, but across a wider spectrum. So as you'll see here, these are individuals, not surprisingly, mostly from the United States, but I am thankful for families who traveled from as far away as Europe, and also people from across North America, including Mexico and Canada. Showing you the age spectrum here, and on the lower right, we did have individuals up to the age of 21, but as we did this, we did have individuals that were skewed again towards children, so children in particular below the age of 10. So just as a limitation in terms of what we're able to see. As we did this, again, looking at the medical history that you all reported to us, again, of those 33 individuals who participated, I'll say that I think these were similar to what we saw in Simon's Searchlight. So I think this is cross-validating what we saw from our larger sample set around the world. Everyone had some history of either developmental delay or intellectual disabilities. Again, we saw 60% of individuals with an autism diagnosis and about 15% with attention deficit disorder. In this case, we had about 2/3 of individuals who reported having a seizure at some point, at least one seizure, and almost 50% of individuals who had difficulty with movement or motor coordination. And again, many individuals with some visual problems. and so significant in terms of understanding what we need to address in terms of sensory coming in. Again, looking at what we did in terms of different assessments of the brain directly. And we had, I will give them credit, psychologists who I think were really very insightful. These are individuals here at Boston Children's who really spend all of their time dealing with children with neurodevelopmental disorders. And I think we're very astute at being able to slide the window of sensitivity to pick the right measure for our children so that they would be sensitive to change. And within this, we ended up choosing a measure for most of the individual that's called the Bailey Scale of Infant Development. Within this, I will say there are some limitations with this. That scale is developed specifically for infants. And so it is designed to be able to measure developments in neurotypical infants during early stages of development when they're just starting to develop certain milestones. In many ways, our children with MEF2C are developmentally at earlier stages. And so in their development, they're acting as if they're more like an infant in terms of development. And so we have greater sensitivity to change around those measures. That produces some limitations in terms of how that scale was developed and how we can interpret the information. Yet I do think it's important to realize that we have adapted that particular measure for a community to be able to have the greatest sensitivity to change. The DAS, or the Differential Ability Scale, is designed for individuals who are higher functioning. We had fewer individuals within that scale, so I'm mostly going to report on the information from the Bailey Scale of Infant Development. And again, one of the things that we realized was that a vocabulary task that we used was very, I think, actually showed us, proved to us, that individuals were able to recognize many things by pictures. And so they're able to process a lot of information and understand the information and point to pictures, even if they're not able to say those words in terms of the words that are related to the pictures. So again, as we think about in the future ways of being able to help support our individuals get more independence and be more functional, I do think this is giving us insight to additional opportunities that we have for our community. And I think that's something we can talk about later if there's interest. Okay, so as we're looking about this in terms of being able to look at the scales, this is one of the things I want to point out is that this Bailey Scale of Infant Development is actually designed in terms of how you use it best for individuals who are less than 5 years of age. So I'm showing you the subset of individuals here who were less than 5 years old. So this is officially the best way to be, this is the way this measure was designed to be able to use. As I'm doing this, just so that you know, for normal infants, the mean score within this would be 100. And for those of you who are sort of numerically inclined, the standard deviation for this is 15. And so within this, being 2 standard deviations below the mean would be a score less than 70. So almost everyone within our community was 2 standard deviations below the mean. And what you're seeing is that each dot represents an individual person, and there is some variability either in terms of the overall cognitive standardized scores or on the right, the language scores. You do see some variability, although the overall cognitive score, that point that you see in terms of a score of about 55, is basically about the floor or about the lower level in terms of where people were performing. So overall, I will say that over time, we may need to think about even greater resolution and being able to develop even more of a sensitive measure for the lower end of the functional scale where our children are. And it gives us insight that we need to be able to sort of augment or increase the resolution or zone in terms of some of those very early milestones and be able to understand that how individuals are changing. As I said, with the language standard score, we see a little bit more variability. Individuals are still challenged as we see this, but we do see a little bit more variability in terms of those scores. Within doing this, this is now looking at individuals over the entire lifespan. So now this is taking individuals and being able to adapt the scores in terms of a way that the measure is being able to use this over the entire age range. And you can again see all the way from age essentially 1 to 21 in terms of individuals. Within this, this is developing something that is a ratio of an IQ score, which is looking at what the expected sort of function of the individual is at that age versus where that individual is functioning currently. And so what we see by this is three different domains on that Bailey scale. One is the cognitive assessment on the top, the receptive communication on the left, and the expressive language on the right. And you can see a similar pattern across all three of those. And again, each of those measures, each person is a dot on this. And what you can see is that over time, that ratio is decreasing. So what that means is that there's a greater gap between where the individuals are versus where their peers are. So this is basically measuring the score of our individuals compared to their peers. And that ratio is again getting lower over time, and there's a greater gap. There's a greater discrepancy or a greater difference over time. So individuals early on are more like their peers, but over time, their peers are gaining more skills, whereas our individuals, that slope of change is lower over time. They're not gaining as many skills over time, so that ratio is decreasing. So with this, what we're going to continue to need to do is this is cross-sectional data. This is one time point that we're seeing. It is not as if this is one person changing over time. These are different people. The next thing we're going to need to do, and the reason we're going to be meeting again in January next year, is to be able to look at people over time, to see the same person measured a little over a year later, almost a year and a half later, and to see what has changed over time, what skills have they increased over time, what more are they able to do, and does this change for different people based on how old they are. So what I'd expect is that younger children may be more dynamic, they may be gaining more skills. Older people may have sort of leveled out. So a 21-year-olds may be what they are. They may not be changing, and so they may be plateauing in terms of where they are. What I'll also be interested to see over time, excuse me, is whether or not the new cohort of younger people are going to be adapting based on what we're learning about the condition and what we're learning and able to support individuals with better therapies, better ways of being able to unlock some of their expressive abilities and therefore able to help them achieve more. So it may be in an interesting way that we see what I call a cohort effect, which is individuals, for instance, born in 2025 may achieve different things than individuals born in 2015 or individuals born in 2005. So we will be watching this very carefully, both for individuals as they age up and even individuals that are born at different times. So within this, as you can imagine, it gets complicated when we don't have many people, and it's why we want to make sure everyone around the world has some way of being able to contribute and participate in some way. So we've done this also looking at motor skills, so how the body moves. This is, again, a standardized score. So we have physical therapists around the world who are trained in being able to use this particular score that we call the gross motor function measure. This is with 66 different items, and so that's why it's called the GMFM 66. Again, along the x-axis is the age of the person. So we can, and each dot is one person. So this is cross-sectional data with a different person over time. And what you can see is that there's, in an interesting way, quite a bit of spread, more spread on this one that we see on the Bailey scale of infant development. So different individuals in general, I've put in this dotted line so you can see that individuals are gaining skills over time. But interestingly enough to me, there's quite a bit of variability. As I said, different individuals able to do different things with different items. So we'll see over time next year when people come back. I will be very interested to see, based on a lot of this variability, will this be more sensitive to change? We be able to see more change in this measure than perhaps we were with the Bailey scale of infant development? I don't know, but we will see, and it's important to be able to see that measure over time to see if there is a difference. We'll be doing both of these measures importantly with the same evaluators, the same equipment. So we will be standardizing this in the best way possible to make it as robust, as reproducible as possible. We will be doing this, like I said, in the strictest way possible to be able to make this the best data that we can. So within this, as we're doing this, I've already given you a prelude, but we're planning, and we've had the family group really at the fore helping to lead the effort. In terms of being able to do this, we have ongoing data collection through Simon Searchlight. People can contribute data from anywhere at any time. It's not only on January 15 and 16, but we'll have those in-person assessments in 2026. And in doing those, we're going to continue with this, taking what we've learned and continuing to now iterate and refine this. And so again, we had to have one data point to understand and get a much better feel for the differences across the community, what people were able to do, what they weren't able to do, and have something where we could put it in a dynamic range of these outcome measures. So as we're doing this, we're going to invite both those of you who have done this before, invite you back again so we can see what's changed over time. We realize there are new people in the community, though. New people have been diagnosed, new people have been born, and so we're going to be as inclusive as we can be and have new people come in as well. Because as we do this, we expect that this will probably not be just 2 time points, but that we will need to continue seeing this over time. As we do this, we're continuing to refine our assessment battery. So as I said, that we can fine tune and be able to see what's changing and when over that life course it's changing so that we can pick up the small differences of things that do change. We realize this is slow. We realize that individuals, we have to be patient, and individuals are not changing dramatically, unlike in contrast to our neurotypical children. And so we have to be able to be very tuned into what is changing. I'm also very, very pleased to say that we have been working with groups from around the world to make sure that this is not exclusively a US study. We have, as I said, picked measures that are very standardized measures that we think are both robust and sensitive to change, but also that many, many other groups are using around the world so that we don't have to have something that is a brand new measure that no one's ever heard about before. We're trying to do things that they have staff that are already trained, reliable in using these same measures, and we're going to have partnerships with a group in Poland as well as a group in Spain. And for any of you who might be listening, would love to have other centers from around the world so that we can be as inclusive as possible, and again, have these complementary ways of being able to do this. I'm very pleased to say that we've set up all of the reliance agreements to be able to share data with individuals from around the world. We're respecting everyone's privacy so that we're not identifying anyone's name, but we're able to connect the dots between Simon Searchlight and each of these in-person assessments so that we can combine the data and work together while respecting everyone's privacy. So as we're doing this, this is just a simple QR code to be able to find out, and an email address to be able to find out more about anything. My team here will be able to answer individual questions that you might have. If you'd like to be able to find out more about travel details or sign up to be able to make sure that you've got a spot, we're certainly happy to do that, and happy to take your suggestions, importantly, for how to make this better. Okay, let me pause there.
Dr. Chung, we can't thank you enough for your time today. It's so important for our community to understand the natural history study and the importance of participating in Simon's Searchlight. And it's easy to do in Simon's. It might take some time, but everybody has the ability to get in there and enter a profile for their child. I'm also hearing you say that it's really important for us to have a wider range in age of our participants.
Sorry, I put myself on mute. So, yes, I'll just give you an idea of why I say that, and if you can think of any ways of being able to do this, let me know. Um, so within this, I've had for other conditions individuals that I've actually identified with the condition. And when I say older, I mean really much older. I've identified individuals in their 40s, 50s, 60s, even 70s sometimes with these conditions. And again, I don't mean to scare anyone, but we don't always know what we don't know. We don't know what challenges we might see into older age periods. And everyone's often asking me, what can I expect? What do I need to do to prepare for my future? And I'll say, and I don't mean to scare folks, but parents, the one thing I'll say that they tell me is that, I worry about what'll happen with my child if I'm not here to protect them. I want to be able to put things in place to care for them, but I don't even know what to expect when they would be an adult in their 40s. Is there anything I can do to get ahead of that curve now? And if we can find those individuals, I worry, and I'll be really specific. One of the things I worry about is that individuals, especially if they're nonverbal or minimally communicative, they can't tell us what's wrong. And so there's often a delay to diagnosis, even for something very simple, because they simply can't tell us what's bothering them or something's hurting them. And so you oftentimes make a diagnosis late, and that late diagnosis is oftentimes associated with a worse outcome. So if there's any way that I can sort of help in terms of this, knowing what to anticipate, we can monitor individuals for those associated conditions. We can proactively test for them and be able to get ahead of the curve. So again, I'm not saying this because I know this to be a fact, but just, think about it for a second. If I knew that diabetes were going to be an issue for MEF2C, and again, I'm not saying it is, but if I knew diabetes were going to be an issue, there's a simple blood test you can do to monitor for diabetes, and we can treat it, and we can make sure that we don't have complications from diabetes because we diagnose it early, not diagnose it after it's been there for 20 years and complications have been occurring as a result of that. So we're trying to think of all the things we need to do to be able to, as I said, get ahead of the curve and make sure that we've got, it's the roadmap for our children. Make sure that we've got the right guidelines to be able to take care of them in the best way possible.
Amazing. Thank you for explaining all that. That's really helpful. We are going to go into the Q&A portion of our presentation here today. We've got Dr. Astrid Rasmussen and Claire Jones with Simon Searchlight. I will switch over to my Q&A slide and we'll be reading off any questions that may have popped up during Dr. Chung's presentation. So team, if you'd like to jump in on any questions and answers, I should say.
Hi, good morning, and thank you for having us here. I represent the Boston Children's side of Simon Searchlight, and I can see that there are some questions here in the Q&A. One is trying to understand a little more what the BSIQ is, why it is relevant for the community, and why this measurement is a useful biomarker. And again, there's a second part of the question related to doing it in Poland that I think was already addressed. But just Dr. Chung, if you could add a little more explanation of why adding the BSIQ and how it is relevant to the community.
Sure. So the BSIQ stands for, and I apologize for not spelling this out, Behavior and Sensory Interest Questionnaire, BSIQ. And so in doing this, this was actually coming from families in terms of what they were seeing and concerns they had about gaps in terms of what we might be measuring. Within this, I'll say that this is a standardized instrument. So it's been something that we can, parents can fill out as a questionnaire, so we can administer it from many different places, and that helps in terms of scalability. And we were trying to get at what we were hearing from you as gaps in the sort of battery that we had. So it was in response to that.
Thank you. Another point that I can see here in the questions is what are your thoughts and ideas to fill the age gaps and finding and including older patients in the study?
So I'm actually open to suggestions here. I'll say that one thing is that for individuals in the United States with autism, and I know that's not many people, but for all of those individuals, we also have a study called SPARK, which stands for Simons Foundation Powering Autism Research for Knowledge, that allows anyone to participate across the United States and access genomic analysis, which would get them to a MEF2C diagnosis, and that's free and they can do from anywhere in the United States. So that's the easiest infrastructure that I have built in right now, and anything we can do to raise awareness again, among the community of individuals with autism, and that includes profound autism, which is what I would expect in terms of the MEF2C adult community, allows them to be able to access that way of a diagnosis. Now, that is not going to be, obviously, that'll be a large number of people, a large number of adults, and it would be hard to know who has MEF2C. So that would be something that, in terms of communicating that out to the community, anyone you know who might be there, we'd love to be able to understand how to access what I think of as the profound adult autism community. I think that's probably the highest yields as we can think about how to wake up that part of the community that I think is probably not focused on getting a genetic diagnosis at this time. I think that's the greatest challenge, is that most of those adults think of this as, what do I care about genetics now? It is what it is, and there's no need to be able to go back and revisit that. Other than that, I'm open to suggestions, and we have thought about adult communities. And one of the challenges, as I said, is that they're not as tapped into getting a genetic diagnosis. Sometimes it's actually their other family members who are motivated. You can imagine adults who might be thinking about having children of their own, siblings, that is, of individuals who might have profound conditions that are concerned about their own family planning. And so it may be a sibling that's driving it. So we've tried communication strategies through those individuals, but I will say it hasn't got as much traction just because they're a hard group. They're not sort of well defined to be able to communicate out to them and raise that awareness. So I'm still looking for suggestions, organizations that might be helpful to get the word out.
Is there anyone of the other participants in this call that could throw in ideas that we have not thought about to identify adults that could be candidates for this? Food
I
for
will
thought.
I will say we've even had one of my own families being willing to be in the Atlantic, the magazine, telling their own personal story to raise awareness. So we've tried to get it out through, people that would just be leisurely reading so that they understand the value of a diagnosis. And importantly, that, it can come literally many, many years later. And I will say those families have found it just to answer the why question, just to understand why something happened to their sibling in many cases, I think has had meaning to them. So hopefully that's helpful if for no other reason.
Would it be helpful or something to explore if the patient advocacy groups such as MEF2C Foundation approached other organizations that cater to adults that were diagnosed with an intellectual disability from a very early age, reach out to those organizations to start spreading the information so that those groups of adults and their caregivers are aware of the fact that this exists, that it is relevant, and hear it from the patient advocacies directly and not only from the scientists.
I actually do think that would be helpful. It's a tight-knit community, and I think understanding, how all the pieces fit together, I think would be helpful. I'll actually, if I can put it in the chat, I'll include the link to the Atlantic piece that so people can understand what I'm talking about.
Thank you.
I'm happy to jump in pretty quickly. So outside of my role with Simon Searchlight, I work in an adult neurology clinic. And so this has been something I've been trying to get some of our adult neurology providers to think about of, it might not change maybe current management, but give families that answer as to why what you just said, Dr. Chung, is to explaining the patient's past history, but also really contributing to that data. And so I think maybe getting into like the American Neurology Association and talking with those types of providers, or even in like primary care setting with an adult patient's not followed by certain providers, maybe making it more aware that genetic testing is an option if it wasn't available back when these patients who are now 30, 40, 50 years old wasn't available when they were 5, 10, 15 years old. But I think one of the barriers, like in clinical care, is still insurance coverage, where there's some insurances that put in their clauses of doing this testing for anyone less than 21 years or older. So I think that could sometimes be a barrier there too.
And maybe that's where we could pitch the opportunity of participating in Spark, as Dr. Chung said, our companion study where people come in without a genetic diagnosis, but with a clinical diagnosis of profound autism or intellectual disability, and we offer the testing that the insurance is not willing to cover. So that's an opportunity there to help them come across that barrier in access to the testing. There's another question here that says, what level of iteration and refinement is typically needed in natural history studies to meet regulatory expectations for therapeutic development? How many patients would this equate to?
So ultimately, the iteration allows us to get down to measures that will be sensitive to change. So I can't say for sure how many cycles this will require in terms of doing it, and or whether we'll have to develop some new measures to be able to go forward. But my hope is that it's not 20 iterative cycles as we go forward. I think we have a much better sense in terms of sensitivity to change. I do think that across the community, one of the challenges is that, and this is true for many neurodevelopmental disorders, that many of the outcome measures that were developed are developed for individuals that are higher functioning, and it's a universal problem, I would say, for many of the developmental disorders like MEF2C. So knowing that there are a group of people that are actually even developing new measures as we're going forward so that we can again be fine-tuned in terms of what we need to develop. So I won't put a cap on it. I mean, we're using everything that's available currently, but we'll also add new measures as they're available to do this. I certainly hope that as we're doing this, as I said, there are other measures like the ORCA is one of them, and other things that again are geared towards individuals that may be nonverbal, non-speaking, and as we're doing this, I think are important to do to really unlock and be able to see all the capability, but not be dependent on speech to be able to do that. It is a little bit challenging, I'll say, and I'll just give you one example, is that some of you as parents who may have noticed this, that even when we were doing the motor assessment, the GMFM, is that you have to be able to understand the instructions and then follow the instructions to do the task. So it's not really just a measure of motor function. It also is, to a certain extent, a measure of comprehension and then being able to follow those instructions to do things. And so it's a little bit, like I said, we are to a certain extent co-opting measures and using them, but they're complicated. If you have trouble, for instance, with vision, and so you're not able to accurately see and navigate the world around you, you may have difficulty performing a task simply because of visual impairments as well. And you saw that although, individuals are certainly not blind, they can have different degrees of problems in terms of vision. So it gets to be a little bit complicated. No one of our tasks is 100% pure in terms of doing this. And so that's why we need to be able to um, just have more people doing this in more periods of time. To give you a sense of numbers, and I appreciate that question, I don't think it's going to be thousands of people that we need, but I do think over the life course, I always put a number of 100 out there, that if you do have 100 as a number and you're able to look at them over time, that does tend to give you robust enough information for clinical trial planning. So we're not quite there yet with the numbers that we have, but in a good way, we've got a really good start. And so I anticipate that we'll be able to get close to those numbers that we need in the not too distant future.
There is another question that I'll direct to you, Claire, as well, and that is about known genotype-phenotype correlations in MEF2C.
Yeah, great question. I think there's been some research done where we're starting to find possible genotype-phenotype correlations depending on maybe where a variant is located within the MEF2C gene. On one of Dr. Chung's first slides where she said it looked like a lollipop grid, there were different like domains throughout the gene. And so there's some research being done on, depending on maybe where a variant is located, could that be correlated, uh, as well as if someone has a larger deletion within this gene, that includes maybe other genes, do they have more significant features or not? So not something I have a solidified answer for today, unless Dr. Chung, you have anything to add, but I think we still need more research to determine if there's a stronger genotype-phenotype correlation.
I will say that as we looked at the data, and I said this, but there are more similarities than differences. So altogether, I do think of MEF2C collectively, it's mostly the same. There may be slight differences, but they're not like night and day differences. So we'll continue to look at this, but this does get to be where we see this change of the same person over time and being able to look at that and then segment it out by different types of genetic variants. But there are a lot of you that are onesies. So what I mean by that is you're the only person, your child is the only person with that particular genetic variant. And so it does become challenging to collapse these and to be able to look at even classes. It may not be as much as a whole class you can put together. There may be subtle differences even by the individual genetic change. So the most important thing is to stand up and be counted to be able to have as many people represented in this as we can.
All right, everyone, we are right at the hour mark, and it does look like we have a few unanswered questions. So we do have a couple approaches we can take. We can get back to people in writing with a summary of some additional answers that needed to questions that needed to be answered. Do we have any time for any more, or would we rather do written responses?
I'll just say very quickly for a couple of the questions that I see. I think we talked about older individuals. I don't think it's due to lack. I think most of it is, as Claire said, most of the adults are not being tested, but I don't know what I don't know. So in other words, I don't know that they aren't, I mean, I don't mean to, be doomsday, but I don't know that they couldn't be dying of something because we haven't tested them to know. And so that is one of the keys to me, is to find out if they are out there, if they are having issues, how do we prevent those issues? But we don't know what we don't know. The pathway for treatment, which I know is ultimately on everyone's mind, I will say that we're taking a very holistic view of this, and some of this is even new to the patient leadership, the family leadership. I am trying to think about what I think of cares for today and cares for tomorrow. So what I mean by that is all sorts of ways that we can support the care of our individuals in our community today, with, as I said, knowing what to watch for in the future, as well as different types of technology that we can develop to help them become more effective in their expressive language, more independent, better regulated, but lots of things we can do with tools that we have today, as well as we think about the tomorrows and using the most advanced genomic methods that we have. And we're thinking with our group of lots of different ways of doing that, genetically based therapies, but I will say those are a little ways off, and so we need to have some things that we can do in the meantime. So we're thinking about that sort of multi-pronged strategy going forward. And then in terms of the assessments, we're happy to even provide in writing what we're planning. That's probably the best way to answer that question, provide a sort of schedule of events of what we're planning for the assessments.
Any additional questions after the webinar can be sent to our address info@usmef2cfoundation.org. Thank you to Dr. Wendy Chung, Dr. Astrid Rasmussen, and Claire Jones for joining us today for all the great information that you provided. And we'll continue to keep our community updated through social media and email. Thank you again, everyone. Take care.